So I'd like to welcome Associate Professor Manuel Garcia-Goni, who is speaking to us now from lovely Spain. I hope you have more sunshine than we have at the moment. And
you can be sure about that.
good. I'm extremely looking forward to interviewing you on your recent paper, The Pathways Towards Chronic Care-Focused Healthcare Systems, Evidence from Spain. I found this paper basically a couple of months ago, and I thought this is exactly what our interest in our NCD online course is about. We are now looking at the health systems, how they cope or struggle or should reform themselves to deal with the burden of chronic diseases. And you have written exactly the paper I'm looking for. So thank you for joining us.
My pleasure.
Can I start a couple of questions, maybe starting with one of the first figures on your paper where you describe the healthcare expenditure. Those lines there, I'm not quite sure. I hope everybody can see that, but everybody will get access to the paper. There you show the increase in healthcare expenditure in a number of different countries. The top, obviously, the winner of the non-game are the United States. We know that with more than 40%. But Spain seems to be almost hidden. It's the red line in the lowest percentage. And the data are from 2009, the latest one. So as introduction, my question would be, well, if Spain is so low, what is your problem? And shouldn't you be happy?
Wow, I think here in Spain we have lots of reasons to be happy, but this is not one of them. Actually, as you can see in the figure, most countries, basically every country, they are increasing healthcare expenditures as a proportion of the GDP. That's basically because the size of the health sector is increasing a lot. There are lots of reasons why this is happening. And well, the latest data we have here is 09, but basically now it's the same number. So basically now we are between 9.5 in Spain and 10% of the GDP. The differences between different countries are clear. I mean, the US, for example, is huge. Now they are about 17% of the GDP, something like that. While in several countries in Europe, like, I don't know, in the Netherlands, in Germany, they are about 11, 12, something like that. And there are other countries like Spain or the UK, and we are about 9, 10, something like that. Basically, what matters here is to understand the difference between the health systems. So whether you have mostly private system, like in the US, you have a social security system, like the one that they have in the Netherlands, for example, or Germany, or some other countries. And then some countries like the UK or Spain with a national health system. And we have a lower proportion of the GDP because prices are much more controlled, for example, and some other reasons. But anyway, what is important for us is to look at the trend, and the trend is increasing a lot. There are several reasons, like aging of the population, the income effect, or the one that is most important right now explaining this, which is the technology assessment. So basically, health technology is the main driver of the increase in health expenditures.
That is an interesting point you're mentioning also in your paper, and I would love to explore that even more. It's not the main argument in your paper, so we leave that maybe for another one. But it's interesting to think about the impact of healthcare technology, especially in care-intensive chronic diseases and conditions. What that means. Yeah. But let me go back on your paper in the health system. There also in the introduction you are mentioning a worry, which in any health system is a worry with chronic disease care, is if the care is suboptimal, if people don't attend screening, if people don't adhere to their often then lifelong management and change of lifestyle and adherence to treatment and medication and so on, that could become very costly in the long run. And
Exactly.
I think you're quoting a figure of 70% of the healthcare expenditure could be related to suboptimal care. I would like to know, how was that established? What is the evidence about that? How can we be sure of that number?
Yeah, so basically we have been looking at individual healthcare expenditures in one of the regions in Spain, which is the Basque Country, and basically we have calculated that about 80% of healthcare expenditures are devoted to chronic patients in our region of, of the case study that we have been looking at in the Basque Country. So, and most of those expenditures refer to multi-morbidity patients. So basically patients with several conditions at a time. That basically means that if our health system is basically ready to take care or to provide care to patients, but looking only separately to each condition, but we don't take into account that they are having several conditions at a time, what happens is that we are not being optimal in the provision. So the idea is to try to be efficient in the provision of health services to our patients. And clearly, the most important patients and the most expensive patients for us are chronic patients, and among those, multi-morbidity patients. So basically, patients with several chronic conditions. And we are not doing that. So basically, we have great specialists. Our healthcare system is quite good in the sense that we have a huge primary care system. And actually it works pretty fine. But the idea is, okay, we are looking, each specialist is looking at their condition, but they're not taking into account that most of our most expensive patients have several conditions at a time. So if we don't take into account that, if we don't go towards an integrated system, we are not being efficient.
Now let me provoke you with another figure you have in your paper, but basically it shows that one needs to understand the data behind the figures to take the right conclusions. And is it figure 2 or 3 or so? There you show selected the most important NCDs: diabetes, chronic respiratory diseases, cancer, cerebrovascular disease, and acute heart attacks over the last, 15 years. And on rough inspection, one could say, well, they seem to be all going down. Again, shouldn't you be happy? It's good news.
Well, clearly it's good news because what we have here is that people are living longer. So basically the idea is we can take care of our patients much better, and the quality of life is getting higher. So our expectancy of life is one of the highest in the world in Spain. So I think we are now in about 85, something like 85 for women, and about 80 or 81 for men. So I think this is quite good. And in this figure, basically we have deaths. So actually it's good to see that we are controlling the causes of death. But still, okay, we are living longer, we are getting conditions. But the fact that they are not dying doesn't mean that they are not sick. Okay, so they do have the condition, and we need to control for their quality of life. So right now, the idea is, okay, it's great that we are controlling the number of deaths, fine, but they are living with the conditions. So now we need to take care of our chronic patients, and we need to provide the best care feasible in order to increase the quality of life and in the most efficient way, of course. Right? So the idea is, okay, we have gained the battle for the quality of life, in a sense, okay, of course we want to increase that, but we now need to go further for the quality of life.
That's right. I think also that might be a particular problem or limitation of mortality statistics, that they conceal the big burden
Yes.
of disease, of morbidity, and as you said, then also you need to add take into account the quality of life as well. So here we are. Chronic diseases are increasing. Healthcare technology might add also to the expenses, the aging of the population. Then, especially in Spain, consequences of the financial crisis might also not help at all. So let's come back then to the main message of your paper in terms of where is the Spanish health system in terms of taking care of chronic conditions.
Well, I think we are on our way. Well, as you might know, in Spain we have a decentralized health system in which basically we have one Ministry of Health, the main national Ministry of Health, but all the health planning and provision competences are in hands of the different regions. So in a sense, what happens is that we have a mostly fully decentralized health system in which we have 17 regional ministries of health system. Okay, ministries of health. So, and each of those are working separately, independently. Of course, there are lots of links between them, and we have the national Ministry of Health working together with all of them. But the idea is that in each different regions, with different needs also, they are undertaking different steps. And well, if you look at the paper, basically the idea is that, well, there are some things that we are doing fine, and there are some things in which we still have to work more and work further. So there is a table in the paper that you have at some, I think you have it there, I don't know, in which basically we have the 10 most important characteristics of the transition system for the chronic care, in which that's one, yeah, that's one. Thank you so much. In which basically we evaluate where we think we are. Okay, of course, everyone could argue on this table. Okay, because in some regions it's a little bit better than in others. But this is about the whole Spain. And mostly, we can say that we are very happy with our primary healthcare system, which is, I think, it is great. And of course, it has some mistakes, and of course, we have some problems that we have to deal with. But it's pretty good at the moment, like universal care, which is basically guaranteed. Okay, but we still have some problems. For example, we are not doing we are not doing as much as we should, at least in prevention or in public health, okay? And we are not emphasizing self-management of conditions for our patients. We are not using integrated care. So basically, our main problem, I would say, that we have lots of very good experts, lots of very good specialists in different conditions, but they deal with patients independently, and we are not taking care of the whole problem of the patient. So we need to go for an integrated care provision in the following years, and we are taking good use of the international of the information system, of the informational technologies, but our system is not quite good still. So there is no transfer of information from one region to the other, for example. Okay, so there are lots of things that in which we are pretty fine. Okay, in these conditions that Chris Ham wrote in his paper a few years ago, but there are some other conditions, some other statements in which we are still not as well as we should. So basically, this is basically the points in which we have to work more in the future.
This table and this assessment is really very important, and I hope that it can drive the policy discussion on how to get there. Why is Spain there? And it goes back to a paper written by Chris Ham. I have it here. That was also only a couple of years ago. It was published actually 2010, and I'll make it available for our students to read those 10 criteria in more detail what they mean. I can imagine that people might get quite upset or query why you have given only 1 point, like for the self-management instead of 2 or 3. And especially, I guess, when you said you have a very decentralized system, so different regions, so some region would say, no, we are much better in this one, and so on. How did you construct the point system, the table, and then how did you deal with the criticism or outcry?
Yeah, well, this is a very difficult point because, as you just mentioned, in different regions, they are in different statements of development for this, for in the different states of development for these 10 points. So, for example, it's very clear for us that in Spain we have universal coverage. So that's for the whole Spain because our system was constructed. Basically, our national health system is only about 30 years old, a little bit less than that. So now we know for sure that it works in that way. At least it is working now that way. We will see what happens in the future because this economic crisis, we will talk about that later, I guess. But the crisis is playing an important role now, okay, in trying to cut health expenditures. But yes, we do have universal coverage. It is mostly based on primary care. So our GPs are a goalkeeper in the sense that they basically sends our patients to specialists, and it works that way, and it was pretty fine. But the problem is that our health system, our national health system, was built about 30 years ago, focused on the care for acute patients. And now our problem is not the acute patients. Now our problem basically are chronic patients. So that's basically the main problem that we are having now. And that's basically where in some regions, like for example in Andalusia or in Valencia or in the Basque Country, for example, several others, also Catalonia, for example, they are more advanced in how they deal with these patients. But in some others, now they have enough problems to get worried about other things, and they are not taking the steps towards this transition. So that's why in this table we have to balance everything. And I mean, having only 1 star in the, for example, in the 4th point on emphasizing self-management of conditions, that doesn't mean that in all the regions it's that bad. But it also means that it's one of the places where we want to focus our attention in the future. So for sure we need to do much more in this point. And for example, also in the like in the 9th point, the coordination of healthcare or the integrated care. So if you see, our main points now are trying to get focused the health policy makers' attention in trying to coordinate the care again, trying to integrate care, the management of patients. So basically the idea is try to give the signals to policymakers that they have to focus their attention in providing a more efficient healthcare system, basically in which we are not dealing with specific conditions separately, but everything has to be together, because most of our patients have several conditions. I mean, most of our patients with conditions have more than one condition, let's say. Of course, we have also a very nice population, very healthy.
Out of interest, we in academia, we've liked writing papers and contribute to the discussion, but quite often fail on really capturing the policymakers. Do you have any indication? Was your paper taken up by some? Did you get any feedback from policymakers?
Well, actually, in some of the regions, yes, we did, but not in all, and not from the ministry. We have to all take into account. First of all, we need to be very patient with this, because well, policymakers right now they have lots of problems to deal with in this situation. So basically, if you look at what the policymakers have done in the last 2 years in Spain. And we actually changed government about 1.5 years ago. So basically, the last government and this government, so both governments are basically in the same line, even if they are in different color. but they are doing policy in the same line. Basically, they are cutting expenditures. So the idea is, okay, given that we have a huge debt, public debt, we need to cut expenditures, public expenditures, and particularly the easiest one, maybe, are wages of public workers and health expenditures. So this is the easiest, and one of the main things that they are doing is trying to control and cut the price of pharmaceutical products. So this is one of the most important things that they have done. And actually they have cut expenditures. They have cut the pharmaceutical expenditures by about something like 15% in a couple of years. Given prices, okay, controlling prices mostly. So the idea is that, yes, they are doing other things. They are in some regions, I would say, with more tradition of competencies in health, planning and provision, like in the Basque Country, in Andalusia, again, Catalonia, Valencia, even Madrid. So some regions, they have longest tradition of competencies, and they are doing better with this problem. But other regions, basically, they are just followers. So the most important thing in Spain is that the regions with more tradition, with more, I don't know, with more innovative regions in a sense in health management, they have to start working with different pilot studies, and they are. So we have different studies now, quite interesting in different regions. And well, for example, the Basque Country, in which I have been working with data from the Basque Country or from Catalonia also, they are doing pretty fine in this. But the point is that at the moment we have different case studies. They have been running in an independent way and with different needs. So the idea is maybe in a few years' time we will have different types of case studies with different needs, with different population, with different actions which have been undertaken, and we will see which of them are working better. And the idea, hopefully, is that we will be able to identify why for this type of population this is working better than any other policy. So, but at the moment, we would like to have policymakers looking at these papers and looking at whatever we recommend. But we have to be patient, because right now the situation is quite hard, and they are dealing with hundreds of problems.
So if you would speculate on the impact of the financial crisis in Spain on this table, how would the table, the first assessment of the current status, how would that change? Sometimes a crisis can lead to better decisions and more long-term planning, but sometimes, as you indicated, a crisis can also lead politician makers to cut wherever, to fix a current budget deficit and have less of a focus on the long-term implications. So if you would rewrite table, the first column, would you give more points or less points, or the same?
No, actually, no. Basically, right now I would say it's the same. Right now it's the same. So the idea is that now in this, I mean, I perfectly agree with your statement. So yes, crisis is also opportunity. So there are lots of things that we have been doing right, but there are lots of things that we are not doing right. Okay, and when we need to be efficient, when we are forced by every market to be efficient in the provision of healthcare services, it's the right moment to do it right. Okay, so it's the right moment to start doing everything in an efficient way, and doing that basically means to go towards integrated care right now, and the coordination of care, and specifically try to identify which are our most expensive patients and provide for them the most efficient care. Because only a few, I mean, we calculated that for the Basque Country, about 4% of the patients, only about 4%, they are responsible for about 30% of total health expenditures. So, and they have several chronic conditions. So if we were able to cut only 10% in those 4% of the cases, our savings will be great. So that's the point. So that's where we have to go. But I admit that it's quite difficult to do that. We need to have a very nice information systems. We are working on them, but we are not in the best states right now. So in other countries, they are in a better situation. But we are on the way. We will be there in, I guess, very soon. So the idea is, yes, I wouldn't change the table. I think we still are. Actually, there are some stars that I would delete now, because yes, because right now policymakers are just trying to cut expenditures and not always in the right direction. Under my point of view, this is of course my opinion. But but for sure there are some things that we need to make sure that we don't destroy what we have. So it's a crisis is an opportunity, but we have to take advantage of that opportunity and do things in the right way, and not only cut and cut and cut. And well, when we have a really huge public debt, and when we have this economic pressure to reduce that debt, sometimes policymakers are not looking at the long run, but at the very short run. And this type of transition towards a economic system needs some investments. And I admit that this is not the very best moment to invest for
Yeah,
policymakers.
but I guess one of the key cornerstones in your policy argumentation is that you need to evaluate the cost benefits of a reformed healthcare approach
Exactly.
towards chronic diseases, that you demonstrate that in the long run the country will be better off investing in certain things and maybe phasing down the more acute care structures and so on. I presume you're working on that
Exactly.
too, to generate evidence for policymakers.
Actually, yes. Right now, with the same co-authors, we are working in the with data from the Basque Country. We have a huge data set with the whole population of the Basque Country, and with all the individual healthcare expenditures and all the uses of resources by every person in the Basque Country. It's more than 2 million. And there then we can identify which type of patients are more important for us, which conditions they have, whether they go to primary care or specialist care or the emergency room. So we basically know where we are spending the money now. So right now is the moment in which we can identify and we can estimate exactly how much money we are spending in just a few people. And which type of services they take. So whether they go too much to the primary care, or whether they take too many clinical tests, or whatever. So the idea is that, of course, when we have a system like ours in Spain with a national health system, in which basically there is no co-payment, but in pharmaceuticals under prescriptions, okay, but otherwise there is no. So you can go to the primary care, you can go to the hospital, you can go to emergency room, and you don't pay. You only pay co-payment in pharmaceuticals, depending on several things. This depends on the law, but right now there are different types of co-payments with different levels for different type of people, okay. So retirees, for example, they pay much less. So the idea is that right now we need to deal with we need to do, I mean, the works, the evidence that we are trying to provide to policymakers, in which we identify the most expensive cases, and right now that we are having some pilot studies in some small hospitals, we can calculate whether there are some differences in the health expenditures of the same profile of patients in some places or in others. So the idea is that in hopefully in a few months or maybe 1 year or something like that, we will be able to estimate which percentage of healthcare expenditures we could save, guaranteeing the best quality of care. Because the problem, I mean, I admit we need to cut expenditures. We need to be able to do everything in a more efficient way. Fine, but always we need to preserve quality. That's for sure. And one of the problems is that there is a temptation to just cut. And sometimes when you cut, you might lose quality of provision. We need to guarantee the quality. And that's why we are working in trying to provide evidence on how you can, guaranteeing evidence, you still can cut expenditures. So hopefully in some months' time, we will have some evidence on that. And then we will see whether policymakers look at our papers or not, because that's another story.
And we will see how the statistics will change and the point will accumulate.
Yes. No, but definitely, yeah. Even if policymakers they don't look much at us. We do work a lot with clinicians. We do work a lot with managers and at hospitals. And actually, they do look at our work. Basically, we work with them. So something very strong in Spain is that even if our policymakers have their own problems, they are really good professionals. And in the last decade, basically, most of the managers at hospitals they are now worried about this problem. So basically, and this happens basically since 2007 when we had the crisis, when we started the economic crisis. Before that, we weren't too worried. There was no such a concern on health expenditures. Now we are on that trend. So actually, this is the next part of the crisis. This is the opportunity that we have. So even if policymakers they are doing their own way, which is fine, maybe we like, maybe we don't, but they are trying. Let's say that they are trying to do the best. We have really huge, very good professionals in the health system. So very good doctors, very good nurses, very good specialists, and very good managers that they are very worried about this. And we are working with them. So we know that no matter whether policymakers are paying attention to us, we are working together in order to improve our system.
Yeah.
So the numbers will
should
come.
also increase your voice if you have the health administrators backing you with the evidence, because they're working at the forefront and have to make do with their given budget and see the disease burden. It shows again and again that I very much like your paper, and I think you're on the pulse of assessing the performance and giving recommendations if countries are falling or regions are falling behind in certain areas. And I'm basically looking forward to talk to you again next year or whenever you come up with new data to see the development, because I think health systems in all countries to more or lesser extent struggle with this problem of chronic diseases. It's sort of new for our health systems what best to do.
Yes.
And I think you're leading the discussion in that way, and I'm looking forward where it leads us and where are the success stories to be shown. So with that, I'll actually like to thank you for your time. I wish you good luck.
Well, thank you. Yeah, thank you. Thanks to you for giving me the chance to present this paper and this work. We are working in this topic. We will be working on this topic in the next years. And well, I will be happy to contact with you again and give you my opinion on what's happening and share our opinions, because you also have a nice things to say, I'm sure, about your system. And well, thank you very much, and I hope this is useful, and well, everything will be better in the next future in the health systems towards these chronic patients, which is the most important.
We share our hopes there.
Thanks.
Thank you very much, and have a lovely day.